Welcome to the deep dive. Today, we're really getting into the heart of it, tackling cardiac dysrhythmias. This is all coming straight from a core medical surgical nursing text.
That's right. And if you're looking to quickly get a solid handle on the heart's electrical system, maybe feeling a bit overwhelmed, well, this deep dive is definitely for you.
Okay.
Our goal here is to lay out a clear, structured path so you understand what's going wrong with these rhythms and, maybe more importantly, the kind of rapid nursing responses they demand.
So let's start big picture, dysrhythmia. It's basically a glitch in the heart's electrical wiring, right? And that messes up the actual pumping action.
Exactly. It disrupts the mechanical ability to pump oxygenated blood effectively.
And the stakes, clinically speaking, what are we talking about?
Oh, they're incredibly high. You've got rhythms that are, well, relatively harmless, all the way up to ones that are immediately life-threatening. And what's really striking is how often these major issues stem from things that seem quite common. Drug side effects, underlying conditions like coronary artery disease, or even just basic electrolyte imbalances like potassium or magnesium being off.
That really hammers home the main principle, doesn't it? The one thing you absolutely have to keep front and center with all these patients.
It does. And that's perfusion. Always perfusion. If the electricity is off, the pump doesn't work right, and blood flow suffers.
Right.
So every assessment you make, every medication you consider, every intervention, it all comes back to, is this patient perfusing adequately?
And it gets complex because, as our sources point out, perfusion isn't isolated. It's tied tightly to fluid and electrolyte balance, often the trigger, as you said, and also to clotting.
Yes, and that clotting piece becomes hugely important later, especially when we discuss something like atrial fibrillation. Big risk there.
Okay, so before we tackle the chaos, we need to understand the normal function, the baseline harmony. Let's trace that electrical highway, the standard conduction pathway.
Good idea. It all starts at the top, in the right atrium.
The SA node, the natural pacemaker.
That's the one, the sinoatrial node. It's got the highest degree of what we call automaticity, basically. Its inherent ability to just spontaneously fire off an electrical impulse.
Right.
That sets the normal pace, typically 60 to 100 beats per minute.
And that signal fires, spreads across the atria. That's the P wave we see on an ECG, right?
Yeah.
Atrial depolarization.
Correct. Then, crucially, the signal hits a sort of checkpoint.
The AV junction.
Exactly. The AV node and the bundle of his. And this area deliberately slows things down. There's a vital delay here.
Okay.
We see that delay as the PR segment on the ECG strip. And it's critical because it gives the ventricles enough time to fill up completely with blood before they get the signal to contract.
Wow.
Maximizes the output. That's the atrial kick.
Got it. So delay for filling, then boom, signal races down to the ventricles.
Right. It shoots down the bundle branches and spreads really rapidly throughout the ventricle walls via the Purkinje fibers. Their whole job is fast conduction. This leads to that big QRS complex. You see ventricular depolarization, and then, finally, the actual muscle squeeze, the contractility.
Okay, let me see if I can nail down those key cell properties then. We've got automaticity, which is starting the impulse, excitability, the cell's readiness to respond, conductivity, passing the signal along, and contractility, the actual squeeze.
That's a perfect summary. You've got the key electrical and mechanical actions there.
And the picture all this creates is the electrocardiogram, the ECG.
Yep. That's our window into this electrical activity. We analyze the parts. P wave, that PR interval, normally 0.1 to 0.150 seconds, showing that AV delay, then the narrow QRS complex for ventricular firing, usually 0.06 to 0.1 seconds, and finally the T wave, which is the ventricles resetting electrically, repolarizing.
Understanding the waves is the first hurdle. Then comes actually analyzing a rhythm strip systematically. There's that classic 8-step method.
Right, and while listing the steps is useful, rate, rhythm, P waves, PR interval, QRS duration, ST segment, T wave, QT interval, the real clinical insight often comes from focusing on a few key measurements.
Like what? Where should you look first for trouble?
After you check the basics, rate, and regularity, you really need to zoom in on the PR interval, step 4, and especially the QRS duration, step 5.
Ah, the QRS width.
Yes. If that QRS complex is wide, longer than 0.1 AU seconds, that's a major warning sign. It tells you immediately the electrical signal is taking some kind of abnormal, slower route through the ventricles. Often means it started in the ventricle, which is generally bad news, much less stable.
Okay, so width is key. And beyond intervals.
You absolutely have to check the ST segment, step 6. Even a tiny displacement, just 1 millimeter up or down from the baseline, can signal serious myocardial ischemia or injury. And the QT interval, step 8, making sure it's not dangerously prolonged, generally less than half the preceding R to R distance.
We learned all these precise measurements, but then there's the potential curveball. The monitor might not be showing the real picture.
Exactly. You have to consider artifact. It's so important.
What causes that?
Oh, lots of things. Patient movement, maybe shivering, loose electrodes, faulty equipment wires, electrical interference from other devices.
And it can look like serious trouble.
It absolutely can. It can mimic lethal rhythms like VFib sometimes, which leads to the #1 safety rule in ECG monitoring.
Let me guess. Check the patient.
Always. Assess the
No.
patient, not just the monitor. If the screen is showing chaos, but your patient is sitting up in bed, alert, talking, maybe even asking for lunch, trust your patient assessment first. Check the leads, check the connections. Don't just hit the panic button based on the screen alone.
Right. Vital point. Okay, so once we're confident the rhythm is real, we need to classify it. You mentioned earlier the rate is a huge factor in how worried we should be.
It really is. We can broadly group dysrhythmias into, say, premature beats, slow rhythms, bradydysrhythmias, and fast rhythms, tachydysrhythmias.
Let's start with the slow ones. Bradydysrhythmias, under 60 beats per minute.
Okay, so a slow heart rate isn't always bad. In fact, it reduces how much oxygen the heart muscle needs, and it actually increases the time the heart spends resting in diastole.
Which means more time for the coronary arteries to fill.
Precisely. Better coronary perfusion time. However, there's tipping point. If the rate drops too low, cardiac output can plummet. Then you start seeing symptoms.
Like what kind of symptoms?
Dizziness, fainting or syncope, confusion, low blood pressure. Signs the brain and body aren't getting enough oxygenated blood.
Okay, now flip that. Tachydysrhythmias, rates over 100, the heart's racing.
And that speed is the problem.
Right.
Initially, yeah, a faster rate might bump up cardiac output for a bit, but if it stays really fast,
Problems arise.
big problems. The time the heart spends relaxing and filling diastole gets drastically shorter. Less filling time means less blood pumped out. Even worse, less time for those coronary arteries to perfuse the heart muscle itself.
Right.
And all this is happening while the rapidly beating heart is demanding more oxygen. It's a dangerous combination.
Let's make this concrete. Basic sinus bradycardia. Slow but otherwise normal rhythm. What commonly causes that?
Often it's due to too much vagal nerve stimulation. Things like vomiting, deep suctioning, even just straining hard, like having a bowel movement. The Valsalva maneuver can trigger it in some people.
And the key is whether the patient has symptoms.
Always. If they're slow but feeling fine, you just monitor. But if they're symptomatic, dizzy, confused, hypotensive, then you act fast.
What are the actions?
Standard approach is IV atropine first, to block that vagal effect and speed up the heart. Maybe IV fluids for volume, definitely oxygen. And you need to be ready for temporary pacing if the atropine doesn't work, either transcutaneous pacing with pads on the chest, or maybe transvenous pacing later.
Okay. And on the flip side, sinus tachycardia. Fast but regular, often a response to something else.
Exactly. Fever, anxiety, pain, dehydration, anemia, even stimulants like caffeine or nicotine can drive the heart rate up.
So the nursing focus isn't just the rate itself.
No, it's about assessing the impact of that rate. The action alert here is really checking for signs of decreased perfusion. Is the patient getting restless or anxious? That could be poor brain perfusion. Is there urine outbound dropping? Poor kidney perfusion.
Okay.
Management is really about finding and treating the underlying cause. Get the fever down, manage the pain, give fluids if they're hypovolemic, try to reduce anxiety.
Now let's move into probably the most common rhythm nurses deal with clinically, especially sustained rhythms. Atrial fibrillation, AFib.
Yes, AFib. It's incredibly common.
And this is where that clotting concept you mentioned earlier becomes a major issue.
Absolutely. In AFib, instead of one nice coordinated signal from the SA node, you have multiple spots in the atria firing off chaotically super fast, like 350, even 600 times a minute.
Wow.
So the atria aren't contracting effectively, they're just sort of quivering. On the ECG, this looks like an irregular ventricular rhythm. The QRS complexes are all over the place, and you can't really pick out any clear P waves. It often looks like a wavy or fibrillating baseline.
And this chaos leads to two big dangers that we as nurses have to manage constantly. First, that clotting risk.
Yes. Because the atria are just quivering, blood doesn't get pumped out effectively. It starts to pool, especially in a little pouch called the left atrial appendage. Stagnant blood clots.
And those clots can travel.
Exactly. They can break loose and travel anywhere in the body. If a clot goes to the brain, that's a stroke. If it goes to the lungs, it's a pulmonary embolism, or PE.
Our sources highlight a critical rescue for suspected PE.
They do. If your AFib patient suddenly develops shortness of breath, chest pain, maybe becomes hypotensive, you have to suspect a PE and activate the rapid response team or call a code immediately. It's life-threatening.
Okay, so massive clotting risk. What's the second major danger with AFib?
Heart failure. Losing that coordinated atrial contraction, the atrial kick, means the ventricles don't fill as well before they pump. Plus, if the ventricular rate is really fast and irregular, filling time is even shorter. This can decrease overall cardiac output by, say, 20%, 30%.
So given these risks, when someone presents with new AFib, why isn't the first step always just to shock them back into a normal rhythm?
That's a great question, and it gets to the priorities. Often, especially if the patient is hemodynamically stable, the first priority isn't necessarily rhythm conversion, it's rate control.
Just slow it down.
Just slow down that rapid ventricular response, giving the ventricles more time to fill, improve cardiac output, reduce the heart's workload. We use drugs like calcium channel blockers, maybe diltiazem, or beta blockers like metoprolol. Digoxin can also be useful, especially if the patient has heart failure alongside the AFib.
Okay, so rate control first. Then you might think about rhythm control.
Right, that could involve antiarrhythmic drugs, things like flecainide or amiodarone, or using electrical cardioversion.
And woven through all of this is the need for anticoagulation.
Absolutely. For almost all patients with AFib, unless they have a very low stroke risk score or contraindications, anticoagulation is essential to prevent those devastating clots.
What are the options there?
Well, there's traditional warfarin, which works well but requires frequent INR blood tests to keep the level therapeutic, and patients need education about vitamin K intake and potential interactions with things like ginger or ginseng.
Right.
Then you have the newer direct oral anticoagulants, the DOACs like rivaroxaban or dabigatran. Big advantage is no routine blood monitoring needed, but you still need to be aware of bleeding risks and know where the reversal agents are kept, just in case, like aducanumab for dabigatran.
Okay, let's clarify cardioversion for a second. You mentioned it's a synchronized shock. Why is that synchronization so critical? How is it different from defibrillation?
That synchronization is key. Cardioversion delivers the electricity timed precisely with the patient's QRS complex. It deliberately avoids firing during the T wave.
Why avoid the T wave?
The T wave represents ventricular repolarization. It's an electrically vulnerable period. If you deliver a shock right on the T wave, you risk inducing a much worse rhythm, like ventricular fibrillation. So synchronization is a safety measure for cardioverting rhythms like AFib or stable VT, where there is an organized QRS to sync with. Defibrillation, used for VF or pulseless VT, is unsynchronized because there's no organized rhythm to sync with. You just need to shock immediately.
Got it. And for patients who struggle with long-term anticoagulation, maybe due to bleeding risk, there are other options emerging, like the LAA closure device.
Yes, the left atrial appendage closure devices like the Watchman implant. The idea is, since most clots in non-valvular AFib form in that appendage, you can insert a device, often via catheter, to basically seal off or plug that appendage.
So no blood pooling, no clot formation there.
Exactly. It's a mechanical way to reduce stroke risk without needing long-term blood thinners. A really significant development for some patients.
Okay, let's shift gears now to the really scary rhythms, the ventricular dysrhythmias. Why are these generally considered more serious?
Because the ventricles, particularly the left ventricle, are responsible for pumping blood to the entire body. If they aren't working right, systemic perfusion drops dramatically and quickly.
We can start with premature ventricular complexes, or PVCs, those extra early beats from the ventricle.
Right. They look wide and bizarre in the ECG because the impulse starts in the ventricle muscle, not following the normal fast pathway. They're often followed by a pause.
What causes them?
Lots of things can make the ventricles irritable. Heart attack, heart failure, low potassium or magnesium are common culprits, even stimulants sometimes.
And the action alert with PVCs, they might look dramatic, but the crucial question is,
Are they perfusing? Is that early beat actually strong enough to generate a pulse out in the periphery?
how do you check that quickly?
You have to simultaneously watch the monitor and palpate a peripheral pulse, like the radial pulse at the wrist. If you feel fewer pulses at the wrist than you hear heartbeats with your stethoscope or see on the monitor, that's a pulse deficit. It means those PVCs aren't effective. They aren't contributing to perfusion.
Okay, now, if you get a run of these PVCs together,
3 or more PVCs in a row is defined as ventricular tachycardia, or VT. That's a run of fast beats, maybe 140 or 180 BPM or even faster, originating from the ventricle.
how you treat VT depends heavily on the patient, right?
Absolutely. If the patient has VT but has a pulse and is relatively stable, maybe conscious, with a reasonable blood pressure, we call that stable VT.
Okay.
The approach there is usually oxygen, Confirm the rhythm with a 12-lead ECG, give antiarrhythmic drugs like amiodarone or maybe lidocaine, and consider an elective synchronized cardioversion.
But if the VT is unstable or worse?
If the patient with VT is unstable, low blood pressure signs of shock, or if they become pulseless, then it's a completely different ballgame. Pulseless CT is a cardiac arrest rhythm,
And it's treated just like
just like ventricular fibrillation or VF.
VF. That's the ultimate electrical chaos, isn't it?
It is. The ventricles are just quivering chaotically. There's no organized electrical activity, no coordinating contraction, absolutely no cardiac output, no pulse. The patient is clinically dead without immediate intervention.
And the single most important intervention for VF or pulseless VT is?
Immediate defibrillation, an unsynchronized electrical shock to try and stop the chaotic activity and allow the heart's normal pacemaker, hopefully the SA node, to take over again.
The critical rescue point here is about timing, isn't it?
Yes, early defibrillation is the key determinant of survival. Every minute defibrillation is delayed, the chance of survival drops significantly. If a defibrillator isn't right there, you must start high-quality CPR immediately while someone else gets the machine.
What about the flat line, ventricular asystole, no electrical activity at all?
That's also cardiac arrest,
Yeah.
obviously, complete standstill. The crucial difference is treatment.
Right. You mentioned you don't shock asystole.
Correct. You do not defibrillate a systole. There's no electrical chaos to reset.
Yeah.
The treatment for a systole is high-quality CPR following the CAB sequence. Compressions, airway, breathing, and giving drugs like epinephrine, according to ACLS protocols, trying to stimulate some electrical activity. Compressions need to be hard and fast, 100 to 120 per minute, and deep, 2 to 2.4 inches.
Okay, that covers the immediate emergencies. Before we wrap up with long-term devices, our sources brought up a really relevant safety issue for nurses working with monitored patients: alarm fatigue.
Oh, that's such a huge issue. It's a national patient safety goal for a reason. When monitors generate too many alarms, especially false or non-actionable ones, staff can become desensitized. They might start ignoring them or delaying their response.
Which is dangerous.
Extremely. But there's progress being made. The text mentions a quality improvement study where they use smartphone technology to filter alarms, sending only the critical ones to the nurse's phone. They actually reduced overall alarm frequency by something like 78%.
Wow, that's significant.
It shows that smarter technology and better alarm management protocols can really help ensure we respond appropriately when an alarm truly matters.
That's a great point about managing the technology. Speaking of technology, let's quickly cover the teaching points for patients getting permanent devices. First, pacemakers. Used for ongoing slow heart rhythm problems.
Right. Most permanent pacemakers are set to a synchronous or demand mode, meaning they monitor the patient's own heart rhythm and only fire if the intrinsic rate drops below a set level.
And when it fires, you need to see.
You need to confirm capture. That means seeing evidence on the ECG that the pacemaker stimulus actually caused the intended chamber to depolarize. So a P wave right after an atrial pacing spike, or a QRS complex right after a ventricular pacing spike.
Okay. And then there are implantable cardioverter defibrillators, or ICDs. Who gets those?
ICDs are typically for patients who are at high risk for, or have already survived, sudden cardiac death due to lethal ventricular rhythms like VT or VF. They can pace like a pacemaker, but their main job is to detect those dangerous fast rhythms and deliver an internal shock defibrillation or cardioversion automatically.
So crucial safety education for patients with either device.
Yes, several key things. They need to avoid strong electromagnetic fields, big large magnets, MRI machines usually, maybe some industrial equipment, or high-output transmitters.
Okay.
They absolutely must carry their device identification card and wear a medical alert bracelet. They should know their pacemaker's set lower rate limit and report any pulse rate that falls below that.
Anything specific about post-op care, especially for pacemakers?
Yeah, particularly with pacemaker-led placement, patients are usually advised to avoid sudden, jerky, or over-the-head movements with the arm on the side of the implant for several weeks, maybe about 4 weeks. This is to prevent the newly implanted leads from getting dislodged before they fully embed in the heart tissue.
Got it. Okay, so we've really covered a lot of ground here. From the basic electrical pathway and how to analyze an ECG using that systematic PQRST approach.
Right. Understanding the difference in impact between slow bradycardias and fast tachycardias, especially regarding filling time and perfusion.
Recognizing AFib as that double threat, the clotting risk leading to stroke or PE, and the risk of reduced cardiac output pushing towards heart failure.
And absolutely nailing down that immediate defibrillation is the non-negotiable priority for VFib and pulsals V-attach.
So for you, the listener, hopefully this gives you a solid framework.
And always, always come back to that core nursing priority. Assess the patient's perfusion. Don't just stare at the monitor. Does that wide QRS come with dizziness? Does that slow rate make the patient confused? Check the patient first.
Excellent summary. And finally, just a thought to leave you with. We talked about the risks of anticoagulation for AFib bleeding complications versus the very real risk of stroke without it. Considering these newer non-drug approaches like the LAA closure devices, how do you think those technologies might shift the long-term management strategy for AFib over, say, the next 10 years? Will they become more mainstream?
That is a really interesting question to ponder. The balance between pharmacology and device therapy is definitely evolving.
Something to keep an eye on for sure. Thank you for joining us for this deep dive into dysrhythmia care.
It was a pleasure. Keep asking those critical questions.
Until next time, keep learning.